Here I am presenting management of delayed sequelae of ocular chemical injury at Tertiary Care Center. I have no financial interest on the subject of matter. Uh, Ocular chemical injury is an absolute emergency which can threaten sight and life. Two broad categories are acid and alkali chemical agents. Alkali causes more damage by the saponification of deeper penetration and as a consequences, while the acid cause rapid coagulation of the tissue which impedes the penetration and limit its damage. Majority of the cases report to our tertiary care center after the mean duration of 48 to 72 hours. Even after the meticulous management of the acute phase, most of them landed into the sequelae. Coming to my first case, a 5-year-old male child presented to our center after 72 hours of the thermochemical injury with hemifacial burn and tense periorbital edema. Child was unable to open eyes, so we could not examine the ocular structures. Ultrasound B scan was done, revealed the normal posterior segment. Conjunctival swab was sent for the culture and sensitivity. Child was managed conservatively with IV fluid and oral antibiotics, and burn wound care was given after the consultation from the pediatrics and dermat opinion. Day 2 of the hospitalization, child was still very uncooperative and photophobic. After all workup of the GA, UA was planned. Lead was on examination. Lead was edematous. Eyelashes were charred. Few carbon particles over the lid margin. Conjunctival congestion with chemosis, and limbal vessels were blanched. Cornea was hazy with epithelial defect noted on after fluorescein staining, but no conjunctival stain. Retained carbon particles in the cornices were thoroughly washed with BSS, and BCL was applied. The patient was further medically managed with the topical broad-spectrum antibiotics, preservative-free lubricants, topical steroids, cycloplegic, and IOP-lowering agent along with the oral ascorbate and doxycycline. Day 7 of the hospitalization, after 1 week of the aggressive management, the child was unable to open eyes, though photophobic. Conjunctival edema reduced, limbal vascularization achieved. 2 to 3 mm of the epithelial defect is still present, so the frequency reduce and converted to the surface steroid loteprednol, rest advised previously. Patient was discharged with the instruction to follow up weekly and SOS, but unfortunately didn't follow for last 6 months and reported with a complaint of reduced vision. On examination, symblephron was noted arising from the lateral aspect of the lid and bulbar conjunctiva, shortening of the palpebral aperture. Cornea was hazy and internal structure hardly visible from the nasal cornea. AC was though formed, conjunctiva quiet, and digital tension seems to be normal, and visual acuity dropped to the perception of light only. Patient was planned for the left eye symblephron release with conjunctival autograft and with AMG coverage, with an ASOC was performed prior to the surgery. Symblephron tissue was excised over the cornea, and corneal scapular polishing was done from the remnant tissue. Bare sclera defect was measured and taken from the contralateral healthy eye. A double-layered amniotic membrane over the fibrin glue was secured with the nylon tanno suture. Coming to post-operative day, eye was found to be, though there was significant corneal edema with lot of watering, graft was placed on an healthy. Standard post-operative care was given with a satisfactory condition. After 2 weeks, there was no improvement. After 2 weeks, there had a dramatic visual acuity of 612. Coming to the second case, a 9-year-old boy presented to the center with a progressive drooping of the right upper lid. Trauma was due to the accidental burst of the lime tuna packet after 3 months back. Yes. On retracting the upper lid, symblephron noted encroaching the 2 mm of the peripheral cornea, causing the mechanical ptosis. Surgical correction was done like the previous case with the symblephron release, conjunctival limbal autograft, and AMG coverage. Post-operative examination, so full and free extraocular movement with a visual corrective, West corrected visual acuity of 6/6 and discharged with a routine medical therapy. 4 weeks after the surgery, child gained a good cosmesis and vision, currently under the routine follow-up. Discussing my case, delayed sequelae of the chemical injury, if not managed adequately at the acute phase, lead to the conjunctival adhesion and persistent epithelial defect, limbal stem cell deficiency and scarring, decompensation and thinning of the cornea, even leading to melting and secondary glaucoma. In our 2 cases, symblephron acts as a delayed sequelae which was managed with the standard medical and surgical protocol. It shows the chemical injury is an entity which needs a multidisciplinary approach with a good restoration of the ocular and anatomical function. Concluding my case, simplifron is the common delayed sequelae of the chemical injury. Educating patient and attendant about the risk factor and the need of the close follow-up is very important in managing the case. AMG plays a vital role in the management of such cases. These are my references. Thank you.
You didn't talk about SLET.
Yes, sir.
You didn't talk about SLET.
Yes, sir.
You didn't mention anything, treatment.
So we didn't perform SLET in this patient.
When you will do SLET?
So SLET generally performed when there is a limbal stem cell deficiency.
When you will do perform?
Corneal complete opacification with vascularization of.
How many clock hours?
More than 6